Good morning. Oh, great. The mic's working. Okay, so I'm going to talk about strategies that we're developing to essentially pay less and expect more. And we're trying to do this by creating innovations that can avert aggressive therapies and enhance utilization of preventative care. And the context in which I will be talking about our work is cancer. So we've heard about the costs of healthcare both on TV and from our previous speakers. And the budget for cancer care is about 7% of the total healthcare expenditures. And you might wonder what we're spending it on. And a large proportion of the costs of cancer care are in actually oncology drug costs. So one of the things that I want to point out is in 2010, our budget was $124 billion, and 34 of that was for oncology drugs in the US. And if you look at the projected costs in 2020, it'll be close to 50%. And obviously these numbers reflect both the cost of drugs and the increasing number of patients. So if you look at the median costs per patient, you can see that there's a similar, if not greater, fold increase in the cost per patient. And it has increased more than fivefold from the 1960s to 2010. So what can we do to perhaps reduce cost? One is something that's beyond my control, regulatory reform, so that the costs of developing cancer therapies, the regulatory process, et cetera, can be brought down in terms of cost. But the other is to think about ways in which we can avert these aggressive therapies by doing more at the front end in the first mile of the cancer care continuum. And I'm going to talk about three examples today. I'm going to talk about first an example where we can provide increased access to referral level care at the community setting, both locally and globally. And I'll use the example of cervical cancer prevention. The second example will be tests that prevent overtreatment of breast cancer patients without the inherent delay and costs of current tests. And the third example is the potential for treatment in an outpatient procedure in lieu of surgery, or methods that can reduce the toxicity of more aggressive therapies. So in the first example, which relates to cervical cancer prevention, the top panel shows our current paradigm: screening followed by diagnosis followed by treatment to prevent cancer. And the bottom panel shows the procedures that are used to achieve this goal. So we start with the pap smear, and then a woman with a positive pap gets a colposcopy with a low-power microscope, and then if she's positive based on confirmatory biopsy, she's then comes in for a third visit to receive treatment by simply excising the area that's diseased. And one of the questions we had is, how can we reduce the number of touch points in the cancer care cascade as a way of reducing costs, but also reducing loss to follow-up and closing the gap between screening and treatment? So we had an idea to essentially start with the diagnostic step, colposcopy, and think about how we could bring that to the primary care setting. And one of the things that we had to do to think about how we could make colposcopy portable and potentially automated is to really reimagine a gynecological exam. So the next slide shows the pocket colposcope that we have developed and converted into a product. And what the pocket colposcope does is, rather than looking at the cervix from outside the speculum, it's shaped more like a tampon and can therefore look at the cervix through the speculum, and close-up views allow us to really reduce costs to a point where it's the price of a digital camera and about 10-fold less expensive than your standard colposcope. And this was developed by my student Chris Lamb, and we have now tested this on more than 500 women across 4 continents. And it's important to emphasize that the pocket colposcope packages in this very small form factor the performance of a clinical colposcope. So you can see on your right cervical images of a, actually it's not normal, it's high-grade disease all around, so I just caught my error here. But the first column shows acetic acid stained images, so the whitening essentially is indicative of precancer. And then Lugol's iodine, which stains yellow in precancers, allows you to see very clearly the presence of precancerous tissue. And then there's a third piece of contrast, which is the vascularization that occurs in high-grade disease. And not only does this colposcope capture all of the relevant images and features compared to a clinical colposcope, the Leisgang optic, but you can leverage these features and automated algorithms to enhance clinical decision-making and allow mid-level providers and nurses to be able to make more of the decisions at the point of care. And I just wanted to show you 2 examples of how we do this. One is simply to use transform images, for example, the Lugol's iodine images, into color channel and color spaces, and then use thresholds to identify those areas that are precancer. And you can see, if you look at the bottom of the first panel, that you can get ROC curves that are comparable to physician performance, which were what we're striving for. By leveraging vascular features, however, you can actually surpass physician performance, because essentially what you're doing is you're taking immunohistochemistry that looks at vascular density and bringing it into the clinical setting. And so on the right, you can see how you can collect images of these neovascularization changes, segment them, and then put them into classification schemes that allow you to get extremely high specificities, which are important when you're trying to reduce overdiagnosis and overtreatment, particularly in the absence of biopsy, which would be the case in many low-resource settings. Next, I'd like to give you an example of how we're trying to bring innovation to reduce overtreatment in breast cancer. And particularly, we're interested in 2 scenarios. One scenario where a woman comes in for breast-conserving surgery, and we're interested in helping her avoid not only a re-excision surgery, but also the side effects of radiation, particularly in women with early-stage breast cancer. And the second area that we're interested in is this idea of being able to predict distant risk, prediction of distant risk, but making it more accessible to a large number of patients compared to genetic tests like the Oncotype DX, which takes about 7 to 10 days to report back on the risk of recurrence. And so the way that we're doing this is we have the ability to bring imaging tools into the surgical suite and be able to image features on the tumor margin. The question is, what kinds of information can we gather that could help us with our goals? And so we've developed this low-cost spectral imaging platform that allows us to image local breast density. And so the basic idea is that if you have a specimen, you can essentially collect information that gives you the ratio of fat to fibroglandular content, so essentially local breast density. And you can essentially overlay that on your image so that you could use it for margin assessment, but we're interested in doing more. We're actually interested in using this local breast density for risk prediction. So on your left-hand side, you see a margin from a patient that has low breast density and from a patient that has high breast density. And you can clearly see that there are differences in the features that we can image with our system that map onto the density of these patients, the breast density of these patients. But importantly, we want to enhance determination of distant risk. And so Oncotype DX is a test that does that. It's about $5,000, and it takes about 7 to 10 days to report back. There's efforts in the field to use pathology and clinical variables to do those predictions. And you can see that we have tried to recapitulate some of our earlier work that's been published on using pathologic variables. And it doesn't do so well in terms of predicting risk as compared to Oncotype DX. But when we combine this microenvironmental information, that's the local breast density, with clinical variables as well as pathologic variables, you get extremely high predictability of a wide range of Oncotype DX scores. And what you can do is you can do this right at the time of surgery. So for an ER-positive patient that isn't getting neoadjuvant therapy, this is the first point of treatment, and you could essentially report back right after treatment what her risk of recurrence would be, and then direct her to the appropriate therapies as needed. Another area that we're working on is to label small molecule inhibitors with fluorescent labels, so at low doses they can be diagnostic, and at high doses they could treat. And we'd like to apply this in the context of breast-conserving surgery. A woman that has a breast-conserving surgical procedure then goes through radiation therapy to ensure that there's no residual disease left behind. And so we're wondering, could we actually use this particular technology to first do margin assessment at the top, where you essentially could look at the excised specimen or the cavity and be able to essentially look for areas or pockets of disease, and simultaneously use this in the surgical cavity to be able to treat the residual disease, so that you could avert radiation therapy for women that are in the earliest stages of a breast cancer diagnosis. We have created in collaboration with Tim Hasted, created this agent that can work across different subtypes of breast cancer. So on the far left, you can see breast cancer cells that are stained with HS27, and then with a competition assay that basically diminishes the fluorescence, showing specificity. We can image that again in breast tumors in vivo, as shown in figure B, where you have a normal window, a triple negative breast cancer cell line, as well as a HER2 positive breast cancer. And what's really neat about this is you can also label cells and tissues topically. And so figure C shows that you can label tumors with HS27, and this is again specific because you can block it with a competition assay and show that indeed the fluorescence diminishes. And then lastly, and I probably should use the pointer, we've actually done this in breast biopsy specimens and shown consistently now in 25 patients that we're able to get significantly higher contrast in invasive ductal cancer of different subtypes compared to just negative breast tissue. So this is a diagnostic piece, but you can also do therapy. This shows essentially a Western blot, as well as degradation of the HER2 protein. And what you can see is that you do see degradation of AKT. These tumors are highly glycolytic. And you can also see that with treatment, you see a degradation in HER2 expression. So what we want to do is combine both the therapeutic and diagnostic capabilities to perhaps bring all of the treatment that is needed to eradicate residual disease at the time of breast-conserving surgery. The last topic that I want to discuss is treatment. So the question is, can we reduce the need for surgery in some patients? And could we also consider lowering toxicity of systemic therapies by essentially treating the tumor first with something that could be done in a non-invasive manner or minimally invasive manner? So when I talk about this, I'm thinking of ablative therapies. And so you have a number of choices, from radiofrequency ablation to thermal ablation with a thermal coagulator and cryotherapy. But one that we were particularly interested in is the use of ethanol, because it's so cheap and could be used locally and globally. And Rob Morhard in my group came up with this idea of using ethanol ablation, but with a twist, basically ethanol jello shots, to really sequester ethanol in a tumor and be able to essentially destroy it. So I'd like to see if I can show you 2 videos that show the impact of this new formulation. So here is just ethanol injected into a squamous cell cancer, and you'll see that food dye, which is added to it, essentially leaks out of this solid tumor. And so you'll have to either inject a lot of ethanol or end up in a scenario where the tumor is not completely treated. Now, with this new jello shot that I mentioned, you can see that you are much more effective in retaining the ethanol, which we know kills cells, where it belongs, and you can actually control the volume and depth by how deep you insert the needle, the gauge of the needle, and the rate at which you inject the agent. So this jello shot basically involves combining ethanol with ethyl cellulose, and when it's not in an aqueous medium, it's liquid, but when you start adding water, you can see that it becomes a gel. And if you look at the gel mass ratio, there's an optimal concentration for ethyl cellulose at 3%, and this degrades over a period of 24 hours at body temperature. And if you compare the jello shot to ethanol in the same tumor model with a single injection and then wait 7 days, in all of the animals that we have looked at, you can see that the ethyl cellulose plus ethanol completely destroys the tumor, whereas you've still got residual disease with the ethanol agent alone. We think that this is a very low-cost consumable and could be used both for treatment of cervical abnormalities in low-resource settings, as well as shrinking the size of tumors before systemic therapies, because we know that with recurrent systemic therapy, a patient can develop resistance and also suffer from the side effects. I'm almost done. I just wanted to say that the pocket colposcope has really allowed us to build a very large partnership. We have now looked at more than 500 women, screened more than 500 women in various studies across the globe. And I think one of the things for us that's very important is to be able to develop technologies that can be used universally. And so we've created this platform, and we look forward to bringing these new innovations into these different sites, because they too face the same challenges that we do here locally. But then, there is, I don't want to leave this talk on a sad note, but I do want to raise a question, which is this innovation paradox. We can build low-cost technologies, but does that mean that we're really going to pay less? So the pocket colposcope is an example of a Me Too technology, right? So from a regulatory perspective, it has a predicate, and we can file paperwork that's only about this thick, and we can get it approved. We can also get a CE mark and get it across the world. But then you've got this technology that looks at breast tissue specimens. It provides local breast density. It provides molecular information, but it's not a Me Too technology. So you've got this problem of having a much bigger regulatory hurdle, much like the case with oncology drugs, and probably less so, but still quite a bit. And so it's a struggle to think about how we can really bring in really new innovations, but keep costs down. So I just posed that as a question for discussion. I want to thank my lab for the great work that they're doing. 3 of my students are here. Actually, my postdoc, Jenna Muller's here. She's working with Rob Morhard on the ethanol ablation. She's specifically working on cervical precancer ablation. Rob is working on the mechanical aspects of ethanol ablation, and Chris Lamb is working with the pocket colposcope and trying to deploy that in various settings. And then I'd like to also mention the NIH grants that have funded this work, and I particularly want to talk about the academic industry partnership that has allowed us to go from concept to product which is incredible because we're not beholden to other forces and can really develop products in-house at Duke and go through the regulatory process. The quick trials has been great in allowing us to deploy the technology in multiple countries, and also a BRP that funded our breast cancer work. So thank you. We're out of time, but it's time for questions.
For those of you whose stomachs are not grumbling too loudly, we will gladly take questions from the mics. And if we don't get questions from the mics quickly, we'll all go eat. But I see someone heading toward a microphone.
Thank you for the talk, Dr. Hager. I had a question. So you talked along during your presentation, you started by looking at lateral flow assays, and you also talked about moving from immunoassay to combining immunoassay and NATs for higher sensitivity, and then moving to a PCB-based system where essentially you wanted to do fluorescent detection as well. So my first question is, was there a real winner between these? Was there a dedicated strategy from moving from LFA, which is really low cost but low sensitivity, to a PCB-based system?
The simplest answer is that we needed, for the nucleic acid amplification work, to hold temperatures at fixed points for a while. We rejected PCR because the thermal cycling is really power intensive, and the isothermal amplification methods lend themselves to relatively low power use. We could keep the device running for the entire 50 minutes on half the power in 2 AA batteries, so that was the primary focus of our DARPA project. However, the questions that came up when we talked to people who wanted to commercialize it, as I said, were, does it have to be too big and how much does it cost? Does it have to be too big? The answer was no. We basically, we had point-to-point wiring in the first device to get it to work. And it was very useful, but on the other hand, there was no reason it couldn't be all flattened out and put onto a single PC board. So there are many ways in which you might imagine this work. You might imagine a very small instrument, the size of a cell phone, with a disposable card. It would look pretty much like the glucose testing systems that are out there right now. But ultimately, if the goal is to get a very low-cost, disposable-based instrument, and the clinicians want it in 15 minutes, the real-time detection is probably the best way to go. Right. So we're, in fact, heavily engaged using cell phones right now to do readouts of the fluorescence in real time. And the cell phone is a very good reader, as it turns out, for real-time amplification. So, and that's not just us, that's been demonstrated a few ways. That would lead you to a single disposable test, as long as it had a power source, and the power source is still probably going to be a USB. So we're envisioning something the size of a USB stick as the instrument, right, and everybody's comfortable with those. And something, you know, cheap enough where you, if you stepped on it or dropped it in the mud and it became unusable, you could replace it for maybe $5 or $10. And per test cost could easily be below that, actually, at that point.
Just have a quick follow-up to that. Do you see this translating further into an actual multi-omic sort of technology where you can, you know, really extend to proteomics or transcriptomics along the way?
No.
Okay.
I'm interested in a few pathogens at a time. I don't think this is a general approach for doing thousands. There are people who are doing sequencing, and the sequencing is probably the way to go for that. This is not a sequencing technology.
Okay. Thank you.
Sure.
Thank you for your talk. I have a question, possibly both of you could answer, but specifically relating to the colonoscope, or I forget how you say it. I was wondering, yes, I was wondering, I saw that you implemented this in a variety of different places in the world, and I was wondering if you faced any challenges in implementing them in different types of settings and different just due to cultural issues or hospital differences, and how you can potentially see ways of bridging a gap or having methodologies for taking one piece of technology that's the same and not having to change it for different settings. Thank you.
Yeah, that's a great question. So we started these partnerships with our international collaborators early. And so we actually had, I didn't show this, multiple prototypes. And we would essentially send them to all these places so that they rapidly provided feedback on the technology. And it turns out that that process of engaging them right at the front end was really important in getting something that was universally acceptable. There is one distinct difference between, I would say, the community setting and the hospital setting, and that is it is most cost effective to disinfect with bleach or hydrogen peroxide, and that's what we've designed it for. But there are some settings where people are concerned about transmission of infection and compliance of, you know, people to using high-level disinfection. So that has posed a challenge in that while we want to keep it cheap and make sure people use it as they should, the way people do quality control is not something we can control, and so we've got to have additional safety measures. And so that's what we see as the biggest challenge, is how do we make sure everybody follows the safety protocols, because this is being inserted as opposed to being on the outside.
We'll take the one last question.
So this is just a quick one for Nimmi. So I think, you know, when you look at cryotherapy or thermocoagulation, obviously one of the supposed benefits is that a minimally trained health worker could conceivably deliver the therapy. I guess I'm curious as to how you envision your proposed gel will be used at the point of care.
Yeah, so not unlike a lidocaine injection before a LEAP. So to keep it safe, you know, we could design a gadget, if you will. We figured out that we need about 2 to 4 injections. So we could literally have, you know, the needles come out, inject at a certain flow rate, certain volume, and then retract. And we could throw it away, or, yeah, we'd have to throw it away. But we could automate that entire process. We know that injections are used to numb the cervix, so it's not completely out of the box in that regard. One of the things that we're trying to do is learn from experience with cryotherapy and the thermocoagulator. What are the training challenges? And I think with both of the technologies, I will say that just as we bring in stakeholders early, we also need to think about training early, and what are the barriers to training, so that gets, if there is a barrier, we're incorporating that into the deployment of the device rather than thinking about it afterwards. So we're engaging the same partners, both for cancer and pre-cancer. We're engaging the same partners to see what their thoughts are on the ethanol gel injection. So, thank you.
This session will be on translation and FDA regulatory issues, and we have 3 speakers from